we're going to be taking questions in a second. Just one question I have to ask. I sometimes submit grant proposals, and it's daunting. I mean, sometimes it feels like someone just was reading Kafka as they were preparing the forms. And I'm wondering about that because we know that patients don't always adhere to medication because they don't understand, and it's too complicated. They just let it go. And I'm wondering if you had that in mind when you were planning your process, your submission process.
Yeah, so our brief proposal is very simple. Often it's 2 or 3 pages of your text and then some pages with your contact information. It's a 4-line budget because we just kind of want to get a sense of how you're thinking about spending your money. So what we're looking for is the idea. And if the idea gets traction, then we go into the second phase and we have a lot of support. We work with grantees to get the information that we need for the larger proposal and from the different organizations. And we work with, we have historically worked a lot with academic organizations. This team works with a much more diverse set of organizations, and we have experience helping them through that.
That's encouraging. Yeah.
What sort of ranges of budgets do you typically see? Sometimes I would issue it when I'm doing this stuff, is coming up with a budget that's is in line with what you guys are looking for.
Yeah. So I talked about the 3 different kinds of grants we make. One is just trying out an idea. Second, once someone has an idea and perhaps some early results, trying to accelerate. It's similar to the accelerator model that I've been observing in New York and other places. And then the third would be spreading that idea and something that has some evidence behind it across. Most of our funding is in the first and second phase, and most of it is under let's say $200,000 to $500,000. We have made $10 million grants and we will do that for national programs. I talked about Project Health Design, which had 8 different grantee teams underneath it. Behavioral Economics has a group of researchers who are doing $100,000 to $200,000 experiments under there. But I would say my advice would be you're more likely to shoot for the $200,000 to $300,000 range. Think about what you could do with that amount of money, or cheaper. I mean, we'd certainly get $50,000 proposals that are interesting, and sometimes someone has an idea of something to do for $50,000, and we say, could you do a little bit more for a little bit more money? But we don't. But if you have an idea, a brilliant idea, and it's going to cost you a couple $1 million, tell us how much it's going to cost. We'll see the nugget, and we have also taken proposals that had a large budget and said, what could you do for less money? We try to really figure out what needs to be done at what price and then reallocate our budget that way.
More questions to Lori at this point? Okay, thank you.
Thank you.
Thank you so much. Our next speaker does not have a presentation. That's no surprise because he's a rock star, in my eyes. Dr. Chidi Ngwaba, also known as the UK's leading lifestyle doctor, is a physician who works on taking a well-known idea, perhaps not incredibly well-known, of the ability to reverse chronic disease using lifestyle interventions, and works to make it happen in various locations. The reason why I say he's a rock star is because I saw him at TEDx in London, and that was my impression. And as a good groupie, I invited him over. I'm building this up. It's better be good. It's gonna be good. And please welcome Chidi.
Never good to be built up like that, really, is it? You can only hit defeat after that. But thank you very much, Tony. Very, very kind of you. I mean, it's always a privilege to come back and visit the colonies. It's a wonderful. I see you're agreeing with me. I heard your accent. Absolutely.
I speak a little English.
Okay. No, you've all been very good. You've all been very patient. I've seen you. What I'd like to do, just to start, before I start talking, if I could just get you all to stand up for me. Wonderful, 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 wonderful. I just want you to remain standing if you were able this week, 7 days, if you were able to eat somewhere between 5 and 10 portions of fruit and vegetables every day. Every day. Between 5 and 10. Very good, very good. We've got some excellent people here. So, for those still standing, remain standing if you've been able each day to drink somewhere between 1 litre and 2 litres of water. Stay standing. Wonderful, excellent. Now, for those still standing, if you've been able to get somewhere between 6 and 8 hours of sleep each night, stay standing. Fantastic, fantastic. You're doing well, you're doing very well. Now, last one, last question, last question. Last question, for those still standing. If you've been able to exercise, maybe half an hour, that includes walking each day, stay standing. Fantastic, we've got 4 people still standing. Yes, give them a round of applause. And my only last question to you all is, how long have you had a problem telling the truth? No, you're doing well, you do fantastically well, that's brilliant. Actually, that's a better response than I usually get, I have to say. Now, don't worry, you don't have to make too many notes now. All I'm going to talk about are 2 stories, if I may. And they're my stories, and I think they're quite interesting stories. You be the judge of that. I mean, the first one starts when I was training to be a surgeon. I was up at the Cambridge rotation for surgery. This is the best surgical rotation in the UK. Papworth Hospital, Adam Brooks Hospital. And I came into the cardiothoracic part of my rotation. And man, you know, those guys, those surgeons are brilliant. And I was in awe of them, you know what I mean, you know what I mean. And I went into clinic one day with my professor, and I was just watching how he did it all. And there's a gentleman who came in, he already had a bypass done and needed to have a redo. And at the end of the consult, basically that professor said to him, well, you know, you're too sick to have an operation. There is nothing we can do. So the gentleman said, well, what am I supposed to do? And he said, there's nothing we can do. So we sent him home to die, basically. And within 3 months, that man was dead. Okay. And it was at that point, and I'd been thinking about it before, but at that point, I then understood that, you know, with all the knowledge we have, with all the research we do, is that the best we can offer? So I then spent a bit of time traveling. I postponed my surgical training, did a bit of time traveling, came here actually, met some wonderful doctors who were lifestyle doctors themselves, and I realized actually there is something we can do. For people with chronic heart disease who are too sick to have an operation, we can actually reverse their heart disease. They're all silent. But it has been done, and I'm sure many of you know that. We can reverse their heart disease with lifestyle change. That's what a lifestyle doctor does. I mean, a lifestyle doctor sounds like a pretentious interior designer. But it is an actual doctor, okay? And we do use medication, we do use treatment, but we also harness the lifestyle. And through that, we're able to do things like reversing diabetes, type 2 diabetes. I do that on a weekly basis. We're able to reverse hypertension. Now, still in medical schools around the world, we're taught that 95% of people who have hypertension, we don't know what causes it, we don't know how to treat it. But that's just not true. Because in the next sentence they'll say, oh, are you stressed? What's your diet like? Are you getting any exercise? Are you overweight? We know the things that cause hypertension. So we're able to reverse those things too. So that is really what led me into the sphere of lifestyle medicine. And I have never regretted leaving surgery. What we're able to do with our patients in transforming their lives, to me, is incredibly rewarding. And that's why I spend a lot of my time going around speaking about it all over the world, really, all over the world. And it actually brings me on to the next half of the story. Because I was in Lagos, Nigeria, and the chief finance minister for Lagos, very important man, he called me over. He said, look, I've been suffering with all these problems. What can you do about it? Well, long story short, I managed to treat him, got rid of a lot of his hypertension, reversed his diabetes. And he said, well, we need this over here in Nigeria. I said, sure, no problem. And we started working on a plan. Several months later, his son became very sick. Within 36 hours, his son died. Brain hemorrhage, all sorts of things, all sorts of problems. But the worst part of it was that the medical care there was abysmal. It was abysmal. This man has so much money, he could do anything. But still, his family are in peril anytime they're sick. And that is actually the state. I don't know if anybody been to Lagos, Nigeria? Right. That is actually the state of Lagos at the moment. Lagos is the third biggest city in the world. It is the most prosperous city in the continent of Africa. There are properties in Lagos that would be much more expensive than the properties here in Manhattan. They have so much wealth, but the infrastructure and their health is so poor. So he asked me, this was many years ago, he asked me to get involved, and actually what he said was, what I want you to do is to bring an emergency care to Lagos and a hospital of the future. That was the directive to me. And when I was asked to do this talk, I was thinking, why do you want to bring me to speak to these fine ladies and gentlemen? But actually, the project that we're now in is really right up your street because it's dealing with bringing agencies together. And let me just explain a bit about what we did. Oh dear, oh dear, oh dear. The host. Oh my goodness. Right. Okay.
No refreshments for me.
Exactly. Everybody else looks at their phones as well now. That's fine. Absolutely. Now, so just to give you a bit of background, what happened then? I said, well, I have never developed a hospital before. I'm a mere lifestyle doctor. That's me being humble. Me being humble. I'm not usually that way. So how are we going to do this? So I have many friends in the United States, and there's a group of hospitals, and I know the chief exec, and I love what they do in America. I love what they do in America. I said, I would love for that to be replicated in the heart of Lagos. So we spent 2 years back and forth, and they have agreed now to establish that same model in Lagos. We're going to do that. Now, the emergency services in Nigeria, in Lagos, if you've ever seen Lagos, you will see traffic. Having an ambulance in a place like that is ridiculous. There are 20 ambulances actually in Lagos for 20 million people. But if you call an ambulance, it will take 5 hours to get to you, let alone getting you to the hospital. So we have now, working with the southeast of England ambulance service, we have recruited all the motorbikes, several air ambulances, helicopters that are going to be involved in this network of emergency care. Now, you may ask, well, how did you convince them, Chidi? How did this happen? Basically, if you have the right idea, people follow, right? You all, people who are startups and business people, you know that if you have the right idea and you can sell it, people will fall in line. And this is such a worthwhile cause. The other one. Dear, oh dear, oh dear.
Co-host.
Dear, oh dear, oh dear. Yeah, but you know that if you have the right idea, people fall in line, and that is what has tended to happen. With the ambulance services, we're going out to Lagos next month. These guys said to me, you know what, we were there 15 years ago in Lagos. We wanted to introduce something, but the government at the time just wasn't behind us. All that has changed now, and at the right time, with the right people, things can happen. Okay, things can certainly happen. So where we are now is that a hospital is being planned. in the centre of Lagos. We have the manpower. We have a lot of the expertise, but I'm sure you all know a chain is only as strong as its weakest link, right? And let me identify something that happened back in Nigeria 2 years ago. There were 10 wonderful surgeons went to Nigeria as a mission trip to perform heart surgery on children. Wonderful. Brilliant surgeons, some from the US, some from the UK. They got there, they did their surgery, every single child died. Every single child died. They couldn't understand. I mean, these guys were brilliant surgeons, they did everything right. So they investigated and investigated, and they found out that the saline drips were contaminated. Where did the saline drips come from? Some guy just got them from some market down the road. That's the sort of thing that can happen in Nigeria. So when you're planning for your healthcare, you have to make every step appropriate. In fact, I said, when it comes to supply lines, drugs, all of that, you have to treat this project as though it's a mini embassy. You don't get anything from anywhere else. Maybe it comes directly from the United States, or it comes directly from the UK or Europe or somewhere, but you cannot leave anything to chance. So I just thought I'd share that small story with you. But that is what's happening in Lagos at the moment. And by the way, when things happen in Lagos, the rest of the continent watches. Because the healthcare is not much better anywhere else. There are some decent places in South Africa, but the continent of Africa is watching Lagos to see what happens. This could improve healthcare in the whole continent of Africa, if we let it, and if we get together. Thank you very much.
Questions? Yes.
Is the hospital being staffed with native doctors, or are you importing physicians from other parts of the world?
Yeah, very good question. One thing about Nigeria, they produce loads of doctors. I'm sure all of you have come across the Nigerian doctors in America. 90% of the doctors from Nigeria leave Nigeria. And they're in Europe and they're in America. And they're brilliant doctors doing fantastic work. The great thing is that we're able to recruit many of them, and they want to go back and help out. But initially anyway, we're still going to have doctors from all over the world. They have to be, it's the standard that counts. We can't leave anything to chance. A lot of those doctors will go back to Nigeria, but we're also using a lot of doctors from America and Europe and even South Africa.
The reason why I asked Chidi to speak is because I was thinking about how can we get support for great health ideas. And I think it's a great story, and you might want to just emphasize it for a second for everyone. What does it mean? Why would an American health system or an American hospital even care about Nigeria? How are the Nigerians able to recruit all these resources and bring them over and help make a difference?
Well, I mean, the friends that I have, they're interested. I mean, they're interested in helping people. We're all interested in helping people. But we want to do it, and it has to work and be profitable. So where can that happen? It can only happen where people have the money, first of all. They certainly have the money in Lagos. And when people talk about mission hospitals and things like that, they're usually talking about going out into the poor reaches of the country. Well, often that doesn't get much traction because, I mean, when you think about Nigeria, you think about corruption. Now, I know you're all thinking that. Corruption, Nigeria, they go hand in hand. They go hand in hand. And it's true, there's lots of corruption in Nigeria. And because of that, in order for you to make anything work in Nigeria, you have got to look after the elite first. That's just how it works. When you have a system in place that works, then the rest, and we have a huge expanding middle class in Nigeria, they will then get the traction too.
You had a question?
So, what do you need from all of us?
Well, I've
Do
just
you ask? What do you need?
even listening to the presentation so far, every person who spoke so far, and every person I've actually spoken to in this room, can contribute. I mean, that level of expertise is needed in Lagos and needed in the continent of Africa. So it's something that you all might want to think about.
More.
Any suggestions for pharmaceutical companies to get involved?
Definitely.
In what way?
To supply drugs. Was that a trick question?
Thanks, Simon. Is it a question of money though, or is it, I mean, when even just dovetailing on Simon's question, do you need them to provide drugs at a reduced cost, or what's the impending need?
Hey, if you want to provide it for a reduced cost, please. Yes, that would be great. But that's not what we're depending on. I mean, we have the money to pay, but this is just a market that I believe will be an expanding one, because the rest of the continent of Africa, the rest of Nigeria, is not going to put up with what it's got at the moment. And it cannot, I don't believe, it cannot depend today on Nigerian pharmaceuticals. I mean, we talk about the saline. I mean, that's just a disaster. Nobody's going to trust that. So if they know that it's coming from a reputable place, it will certainly work.
Right. Yes.
So is this going to be a privately owned network of hospitals that essentially serve the elite of Lagos?
No, it's going to start as it's going to be a private hospital. We're talking about a private hospital with a network of what we call field hospitals that will sort out for the emergencies. Okay, that's a private hospital. Once it works, and obviously it will work, then that could be replicated. Now, farther down the line, and because I'm talking to the people in the government, they would say, well, look, if it works like that, we would have to find a way to make that work for the masses. That's a different calculation. Okay, but not at the moment. It's a private thing.
So what are you doing in terms of the support staff, nursing, technicians, radiologists, people like, I mean, not radiologists as support staff, but radio technicians?
Yes.
Are you setting up a sort of university to get people on board, or?
Yeah, and that, thank the Lord, that is what the hospital group, it's a Florida hospital group, you may know them. They're involved in that. So where they are in the States, even if we want to recruit people from Nigeria to come out and be trained to a sufficient standard to go back. But in the meantime, there will be people from Florida hospital group going out there and doing the work, plus training.
Because even in the States, I mean, we have, a very high-level healthcare system, and we still have clinical errors,
Of course.
infections,
Everywhere.
mines.
Everywhere. But what we're trying to do is to make this program at least as good. At the moment, it's done Vulcan.
Great, thank you.
Are you using telemedicine as part of the network, and do you have the local network infrastructure to support that?
That is a very good question. It is absolutely essential that we have telemedicine. But when you talk about the local infrastructure, it's not quite there. Yeah? It is not quite there, let's be honest. That is something that's being worked on. And we've got people at NASA, some senior scientists at NASA working on this problem for us. But for me, that is a crucial part of the deal.
I wonder,
Go ahead.
just on
Lauren.
that point, I wonder if the technology, I would expect it certainly wouldn't be there for the provider-patient interaction on the scale that you would hope, but maybe applying the model that I described where you have specialists here talking to providers there.
Exactly.
That might be to produce local knowledge.
That's what we were thinking of, but as I've been told by the engineers, that the scope for that at the moment isn't quite there, so they're working on that. That's basic, but we still don't quite have that. How come I'm getting so many questions, by the way? This is just because of the last one.
Go ahead, Steve.
I'm curious if you have circumscribed what your definition of emergency medicine is. For example, if a person has a chronic fatal condition like AIDS, is such a person falling within your definition of emergency, or is it just, a transplant person who would be considered a candidate for emergency, or a surgical person? Because after all, conditions like AIDS, if they're fatal and they're widespread, could overwhelm a university.
hospital or a teaching hospital like that?
Yeah, I mean, I don't think we're going to be overwhelmed by that sort of problem initially. And the reason being because of the demographic that we're going to be seeing. I'm 100% aware of that. In fact, I started this off as more of a trauma-based emergency care. But I was informed, and I looked at the statistics, that actually from a certain demographic, trauma is not the big issue. For those people who can afford care, trauma is not the big issue. There will be trauma, but it's more heart attacks, strokes, things like that. That's where it starts. And you know, you cannot possibly try and serve everything at the beginning. We have to make something work first.
One last question.
Yeah, just, I wanted to ask about something you mentioned earlier, which was reversing chronic conditions
Yes.
through lifestyle changes.
Okay, yes.
So how do you see that sort of working into, a system like we have in the United States, which is very clinically proven, therapeutics based and moving towards a little bit of a technology focus? So how do you work in those lifestyle based
Yeah, okay.
treatments?
Well, I'll answer that by saying what we do in England. Okay, now England has a different system of the National Health Service, or you like to call it social medicine. It's got a different connotation to it, social medicine. So we have the National Health Service where we pay for it out of our taxes. Right? So we don't want to spend a lot of money on the National Health Service, even though it takes about 30% of our GDP. All right. So it's not a big sell for me to go to a primary care physician and say to him, well, you know what, if we can get many of your patients onto this program, you're going to have less complications of obesity and diabetes and stuff like that. And for those who are on it, we can reverse it. It's not a big sell because the patient wins, the doctor wins, and the country wins. Yes, it's a different system here. But what I've found is that every system I've come across, whether it's in Africa, America, or Europe, there are huge gains to be made. I know, in fact, you've got some very good lifestyle doctors in this country. Very good lifestyle doctors. Dean Ornish being one. I don't know if you've heard of him. Dean Ornish. Well, he is now working with the government on how that can be introduced in this country. And he's got a pilot study done with insurance. I think he's the first physician in this country to get lifestyle medicine onto an insurance program, and it took 15 years to do that. Dean Ornish is his name. So, and I was just speaking to him several months ago, so I know it is definitely possible in this country. It's definitely possible.
Amen to that. Thank you so much,
Thank
Kitty.
you.